Hello and welcome to the third video in our Chapter 22 video lecture series. In this section, we are going to talk all about the innate immune system. Now, this is going to be a hefty video, so feel free to take breaks as we go along and make sure to do some reflections and write down some concept maps on how you can bridge some of this information together and commit it to memory. So we're going to start off with revisiting some of the characteristics of our innate immunity. We know that it prevents entry of harmful substances, and it'll respond non-specifically to a range of harmful substances. And our innate immunity is going to divide into our first line of defense and second line of defense. So our first line of defense, I always like to think of as being those physical barriers, our skin and our mucosal membranes, whereas the second line of defense will involve internal processes, and I always like to say it's kind of like the immune cellular communication of these cells with one another. So we will see things like activities between our neutrophils, macrophages, dendritic cells, eosinophils, basophils, and our NK cells. We'll also see some chemicals released such as our interferons and our complement proteins, and then physiological processes which would include inflammation and fever. So let's focus first on preventing entry from into our body, really our first line of defense. So a few of the microbes can penetrate our intact skin. We know that our skin creates that physical barrier through our epidermis and dermis, the two layers of the skin, and our skin has some antimicrobial substances such as our sweat glands secreting sweat, which would include, of course, a salty environment that certain pathogens cannot stand, and our sebaceous glands, also known as our oil glands, that are going to secrete sebum. Now, with both of these combined, we are going to have some protein-like substances such as dermacidin, which is a protein that's going to act as an antimicrobial peptide to protect our skin from pathogens. We also have lysozyme, which is an enzyme that is an antimicrobial agent, and it helps to break down the cell walls of bacteria, viruses, and fungi. We also find it within a lot of our bodily secretions, which would include our tears, saliva, and milk. Sebum is going to help create our acidic mantle so that certain pathogens cannot withstand that pH level. And lastly, we have our defensins here that are small peptides that are antimicrobial and also function in wound repair. So the other physical barrier that we have are mucous membranes, and they line our body openings. And within those membranes, we're going to produce mucus and release antimicrobial substances as well. So we already talked about the defensins and lysozyme, but we also have an immunoglobulin, specifically A, that is going to be found within the secretions that will combat our pathogens. And then we have various other mechanisms and secretions in our body within the innate immune system. For example, our respiratory tract contains cilia that help to remove debris or trapped microbes. Our GI tract can utilize saliva or the stomach acid to also kill ingested microbes. And then we have the mechanism that would still fall within our first line of defense, which is commensal microflora. And this is known as our normal microflora and will consist of microorganisms that reside on our body surfaces, for example, our skin or our GI tract. And at first, some may be thinking, do we really want microbes within our body? But these are non-pathogenic. And the reason we call them commensal microflora is because when we have commensalism, it means that there's a neutral relationship between two organisms where neither are going to benefit from the other, or it's not going to cause any harm. And this is essential for our immune health. In fact, we have trillions of commensal microorganisms, which is 10 times more than the cells that we have within our body. And we are basically taking up real estate within our body by having these microorganisms in place. They start to interfere with the attachment of potential pathogenic organisms that can enter our body. So if the pathogen doesn't have a receptor or an area in our tissues to bind to, then chances are it is going to get flushed away, coughed out, or in some other mechanism be expelled from our body. All right, so now let's talk about our second line of defense. Just in case the pathogen is able to get past that first line of defense, we're going to start to use some of our internal defenses. And that's going to include certain immune cells, antimicrobial proteins, inflammation, and fever. So we're going to get into specific cellular functions now. First group up is our phagocytic cells. Remember that phagocytic means that the cell is able to eat up debris or other cells. And this is going to include our neutrophils, macrophages, and dendritic cells. They, as far as the neutrophils and macrophages, are going to destroy pathogens by engulfing them. So they take the substance up through a vesicle, and it fuses with a lysosome, which forms a structure that we call phagolysosome. And then digestive enzymes are going to start to break down that cell or a part of that cell. And then we get some residue or debris that is then exocytosed. We have what's called a respiratory burst that produces a reactive oxygen-containing molecule that is going to help to destroy that molecule within that phagolysosome before we exit through the exocytosis. Then we have our dendritic cells here. These will destroy particles and present the fragments. Remember, I said that this was called an antigen presenting cell, and the macrophages will also do the same thing. And these antigens are presented to our T lymphocytes that will work within our adaptive immune system. So even though the dendritic cells are very active in our innate system, this is how we are linking it over to the adaptive system so we can start getting it to work within the next few days. The next category will include our pro-inflammatory chemical secreting cells, so our basophils and our mast cells, which will promote inflammation. Our basophils circulate within the blood, and our mast cells are the ones that reside within the connective tissue, our mucosa, or in certain internal organs. And both of them can release granules containing chemicals. These chemicals help increase movement of fluid from the blood to the injured tissue. So this is going to be a mechanism that comes into play when we discuss inflammation later on as well. So we call this chemotaxis chemicals. Think chemo for chemical, taxis, I think taxi, right? Taxis are always moving. So this is releasing the chemicals and allowing other immune cells to be attracted and want to move within the area. And then the chemicals that are typically released are histamine, which will increase vasodilation and also increase capillary permeability. So as our immune cells are moving through this capillary, they are going to be more readily able to leave the capillary and move within the tissues where the damage is taking place. We can also release heparin that is going to act as an anticoagulant, and then our eicosanoids that are released from the plasma membrane that also will increase the process of inflammation. All right, next up we have our apoptosis initiating cells. And first up is our NK cells, or natural killer cells, and their job is to destroy unhealthy or unwanted cells. These NK cells first form in our bone marrow, and then they begin to circulate in our blood and accumulate within our secondary lymphoid structures, like we said, the lymph node, the spleen, and so on. So they really perform an immune surveillance for us and patrol the body to find these unhealthy cells or maybe cancer cells. They'll also search to destroy virus-infected cells or bacterial-infected cells and cells of transplanted tissue just because they see it as foreign. And the way that they kill is they release certain cytotoxic chemicals. First is perforin, which creates a transmembrane pore that sits within the plasma plasma membrane of that unwanted cell. And then the granzymes that the NK cell also releases then moves into that cell and causes it to go through apoptosis, which is cell death that causes the cell to shrivel rather than lysing and bursting. Now let's talk about what happens when you get infected with a multicellular parasite such as a parasitic worm. Our eosinophils, which are white blood cells, are going to help combat these types of infections. They degranulate and release enzymes and other toxic substances, and they can release proteins that are going to form a transmembrane pore in the parasite cells. They'll also participate in immune responses of allergy and asthma. So when that allergen enters our body, we have an antibody attached to it, and it forms an antigen-antibody complex that the eosinophil then targets and goes through the process of phagocytosis. Our cells of our innate immune system are going to recognize microbes because they are going to have foreign receptors to us. They will have receptors called pattern recognition receptors, also known as toll-like receptors, on their cell surface. Next, let's talk about how our antimicrobial proteins are going to assist in our defenses. What we mean by these proteins is that they are molecules that are going to function against microbes. And so our first class are interferons. These are cytokines that are non-specifically set up to interfere with the spread of intracellular pathogens. So this would include our viruses and intracellular bacteria. So for instance, if this cell over here was infected with a virus, then it's going to start secreting cytokines of interferon alpha and interferon beta. And this is going to travel to our healthy neighboring cells and prevent their infection. It does this by triggering a synthesis of enzymes that are going to destroy viral nucleic acids and inhibit synthesis of viral proteins so that we stop building those viruses. And it also stimulates our NK cells to destroy the cells that are already infected with viruses. You could see them going through apoptosis in that mechanism we talked about earlier. And then the NK cells as well as T cells are going to stimulate the macrophages so that they can destroy the virus-infected cells. Another class is called the complement system. There's over 30 plasma proteins that make up this system, and they work along with our complement antibodies. So we are going to name these proteins using the letter C, and there will be a number that follows based on when they were discovered down the line. These complement proteins are synthesized by the liver and are continually released in an inactive form. And so we have to activate them in order for them to function properly, and an enzyme cascade takes place. So there's technically 3 different ways in which we can get these pathways to go. We're going to talk about the classical pathway in which an antibody attaches to a foreign substance and then the complement binds to the antibody. And the other method is an alternative pathway where the complement binds to the polysaccharides on the bacterial or the fungal cell wall. And this is especially potent against bacterial infections. And we are going to see the effects of it over here, where we can increase inflammation by enhancing the activities of our mast cells, our basophils, which are going to attract our neutrophils and macrophages. We also have the process of opsonization. This is when we are going to bind to the pathogen itself, and then it will essentially signal the phagocyte to come on over and gobble it up. Then we have cytolysis, in which the complement proteins are going to work together to create what's known as a MAC protein, which stands for membrane attack complex. And that allows almost like a pore to open up, and fluid will enter the cell, causing it to lyse. And then we have elimination of our immune complexes. This is what I was talking about earlier when we have that antigen and antibody binding together to create a complex. The protein, complement protein, then is going to attach along with our erythrocyte, and the cells move to the liver or the spleen where it is going to be stripped off. Another non-specific internal defense is going to be inflammation, and this is going to be an immediate response to ward off our unwanted substances. It usually is going to be found more local, and it's a non-specific response to vascularized tissue, to injury and infection, and is a major response of our innate immunity. So the events of inflammation is that our tissue becomes injured, our basophils and mast cells are going to take action, and the infectious organism is going to release chemicals that initiate the response. We'll see chemicals used like histamine, leukotrienes, prostaglandins, and chemotactic factors. Let's talk about the more specific details here. So we have this example of this little boy hitting his knee here, and so what's immediately going to happen, you could see some bacteria has entered this area, is there's a release of chemicals that are going to cause a vascular change. We'll see vasodilation, so a widening of this vessel here, and an increase in capillary permeability. And so we'll have increased endothelial expression of molecules for leukocyte adhesion. So these are called CAMs, or cell adhesion molecules, and essentially they're kind of like these road bumps, right? So that the leukocytes will slow down. I should be going in this direction. The leukocytes will slow down, and eventually they will find a gap here between the endothelial cells and start going through the process of margination, and that is going to allow the white blood cell to go through a process called diapedesis, where it escapes the blood vessel and makes its way into the tissues. Now these white blood cells know where to go because of chemotaxis. They migrate toward these chemicals that are released from the damaged, dead, or pathogenic cells. And our leukocytes are going to release cytokines stimulating leukopoiesis in our bone marrow, and the macrophages will release pyrogens, which will allow for heat to take place. This is a fever-inducing molecule. And then we're going to start having our plasma proteins delivered here, and this is going to include our immunoglobulins, our complement proteins, clotting proteins, and our kinins. The clotting proteins will form clots that wall off the microbes, and the kinins stimulate pain receptors and increase capillary permeabilities, which increases the production of those CAMs by the capillary cells. Our kinins are produced from inactive kininogens from the liver and other cells, and this will include bradykinin. And so once this inflammation process takes place, we're going to have fluid that we call exudate that moves from the blood to the injured or infected area. And the fluids, protein, immune cells are going to work to eliminate the pathogens, which will promote healing. We'll have that vasodilation that's helping to bring more blood to the area, and this is going to increase the swelling and also bring in heat and that red color. And we get contraction of the vessel. Our endothelial cells open between and create gaps so that we can increase that capillary permeability. We lose those plasma proteins, which causes a decrease in capillary osmotic pressure. Thus, it's decreasing the fluid reabsorption into our blood. And the extra fluid that's taken up by our lymphatic capillaries in the area is kind of a washing, because we're carrying away the debris, allowing our lymph node to monitor its contents and possibly catch any pathogens that they find within it. And then within 72 hours, the inflammatory response is going to slow down. The macrophages eat the bacteria, any damaged host cells, and any neutrophils that have died. And our tissue repair process can begin as our fibroblasts form and create new connective tissue. So let's go through the cardinal signs of inflammation. You probably already know these by now, but let's list them again. So first is redness. Again, this is because we have increased blood flow there. Our heat is from the increased blood flow as well, and increased metabolic activity within the area. Swelling is because we have an increase in fluid loss from the capillaries. So again, that increased blood flow helps with that. And the capillaries being permeable, allowing more contents to leave, right? And then pain from stimulation of our pain receptors. Also, don't forget that we have extra fluid in that area, so that compresses our free nerves. And we have chemical irritants such as our kinins, prostaglandins, and microbial secretions. And then the fifth one here, sometimes people forget it, it's the loss of function. And this is from the pain and the swelling in severe cases, which doesn't allow our tissues to function properly. The duration of an acute inflammation is about 8 to 10 days, and chronic inflammation has detrimental effects. Now, we can induce a fever known as pyrexia, and this is abnormal body temperature elevation, 1 degree Celsius or more from normal, which is going to be 37 degrees Celsius, and it results from a release of pyrogens. For example, IL-1 is a pyrogen, and it comes from our immune cells or the infectious agent itself. The events of our fever is that the pyrogens start to circulate through our blood and target our hypothalamus, which we know is regulating our body temperature. Our hypothalamus then releases prostaglandin E2, and the hypothalamus starts to raise the temperature set point in our body that leads to the fever. So we have our stages of fever. Let's just review them on the next slide here. So we have onset. This is when our temperature begins to rise. Our hypothalamus is stimulating constriction of dermal, in our skin, blood vessels so that less heat is lost. We have shivering of our muscles that creates heat, and we know that this is chills. And then we enter the second event, which is stadium. This is when we have elevated temperature that is maintained. Our metabolic rate starts to increase so we can promote elimination of harmful substances. And then our liver and spleen are going to bind zinc and iron, which slows the microbial reproduction. Then we have our defervescence, and this is the time when our temperature starts to return to normal. Our hypothalamus, it doesn't have the pyrogen stimulating it anymore. The prostaglandin release decreases, and our hypothalamus stimulates mechanisms to release heat. And an example of this is when our vasodilation of the skin, blood vessels, or sweating takes place. Our benefits of the fever is that we inhibit reproduction of our pathogens. We're promoting interferon activity, we increase adaptive immunity, and accelerate tissue repair. We're going to get more of those CAMs on our endothelium so that we can pull in more white blood cells and some additional immune cells to migrate out of the blood as well. And so it's recommended to leave a low fever untreated. Now, risks of high fevers come in categories. So low fever is about 100 to 101 degrees Fahrenheit, intermediate is 102, and high grade is 103 to 104, and dangerous high grade is over 104 degrees. You want to seek physician help if the fever is intermediate or high grade, or if the low grade persists for days. Risks are that we get changes within our metabolic pathways and denaturation of our proteins, and it can lead to possible seizures, irreversible brain damage at greater than 106 degrees Fahrenheit, and death is likely if we go above 108 degrees Fahrenheit. Now, sometimes we'll see pus in the exudate, and this contains the destroyed pathogens, dead leukocytes. More specifically, our neutrophils is what we're going to find, our macrophages and cellular debris. It's removed by our lymphatic system or through our skin, and if not completely cleared, it can form an abscess. The pus is walled off with collagen fibers that surround it. We're going to talk more about this in pathophysiology, and usually it requires surgical intervention in order to remove it. Now, a clinical view is applying ice for acute inflammation. It is recommended. It can cause vasoconstriction of our blood vessels, which decreases the inflammatory process. It'll also help to numb the area so it's not as painful for the patient, and it can delay or interfere with inflammatory response, so the healing may be slower. So you do want to just use it minimally, usually for about 20 minutes. Now, if you have chronic inflammation, that means the inflammation is continuing for longer than 2 weeks, and it's characterized by macrophages and lymphocytes, not our neutrophils, and it can occur from our overuse injuries such as tennis elbow, shin splints, or osteoarthritis. It may occur if the acute inflammation is unable to eliminate the pathogen, or it may be due to an autoimmune disorder, and it can lead to tissue destruction and scar tissue formation.